about dosing and individualisation of hormones for each person. So I hope you've had a great day, and I have had so many questions. And some of you might know I've been at Carfest this weekend, amazing festival, really family friendly. And I did 4 sessions. One of them was just an open Q&A, and it could have gone on for so much longer. We didn't have time to answer all the questions, but a lot of people were even coming up to me in the festival, and the commonest question was, I've been told I can't have a higher dose. What's this all about? So I just thought I'd talk through about dosing, because we're all different. So I thought I'd start with some basics, and I will include most of the answers for the questions that you've kindly sent in. So I'm talking about, when I say HRT, I hate HRT. Some of you might have seen my post yesterday was saying about not liking the word menopause. I feel like I'm getting into quite a grumpy middle-aged woman. But HRT is quite misleading. The hormone bit is fine, apart from we've got hundreds of hormones in our body. So it's not actually specifying what the hormones are in the H bit. Replacement isn't completely accurate, because we're not always replacing hormones. Often we're topping up hormones, especially when we give them to women who are perimenopausal or women with PMS or PMDD. So that's not quite right. And then the T stands for therapy. Now, therapy sounds like you need to be on a couch, and it's more of a sort of psychological talking treatment. So I don't really like HRT. And then some people call it MHT, so menopause hormonal treatment. Now again, the M bit isn't right, is it? Because many of us start hormones when we're perimenopausal, so we're not officially menopausal. And again, the H for hormone, which hormone do we call insulin MHT? Because it's, well, you can't do the M, but you call it hormone treatment. It's very confusing. So really, we should be calling them what they are, I think, like the same way we call insulin, we call thyroxine. So we should be calling the hormones, shouting them out individually, because they are individual hormones. They work differently in our body. And so the 3 hormones are estrogen, progesterone, testosterone. But when I say estrogen, I actually mean estradiol, and there are different forms of estrogen. Estradiol is the commonest one that we produce, and it's the most anti-inflammatory type of estrogen. It's a good estrogen, if you like. We also produce estrone, which is a pro-inflammatory. It increases inflammation, and it's produced by our ovaries, but it's produced by our fat cells. And as we get older, as we become menopausal, if we don't take hormones, our body shifts actually and produces more estrone than estradiol. Now, if you think about HRT, or the hormones that we prescribe, then it's been a real confusion, and those of you that are coming to my tour will learn so much more about this, because it's a lot that I'm going to be talking about. But basically, when we say estrogen, then it's not always the natural estradiol. So estrogen in all the contraceptives is synthetic. It's been chemically altered. In the past, estrogen in HRT is synthetic. It's been chemically altered. Most of the studies, when they show any risks with HRT, have been using synthetic hormones, and the estrogen that's been most studied is something called conjugated equine estrogen. The clue here is in the equine, it means horses. So it's actually come from pregnant horses' urine. Now, pregnant horses do not only produce estradiol, in fact they produce a very small amount. In the conjugated equine estrogens, only about 5 to 10% of that formulation contained estradiol. A lot was estrone, and a lot was other estrogens that we don't produce, horses produce, but we were still getting them as part of the conjugated equine estrogen. So of course, they're going to have different effects in the body metabolically. Some older types of tablet estrogen and tablet estrogen and progesterone HRT contained in synthetic estrogen. So that's why it's really important, I think, to be really pedantic and be really clear. When we're talking about estrogen, or when I'm talking about estrogen, I'm talking about estradiol, not estrone, not conjugated equine estrogens, the pure estradiol, because biochemically, metabolically in the body, it's completely different to other estrogens. So when I use the word estradiol, I mean what I say, it is the pure estradiol. So we've got estradiol, progesterone, and again when I say progesterone it's important to be really pedantic here as well, because what I'm meaning is the same chemical structure, progesterone, as the progesterone we produce from our ovaries, from our brain, from other areas in our body. But a lot of people call progesterone when they mean a synthetic progesterone or a progestogen. So all the progesterones that are in the contraceptive pill, in the Mirena coil, in the implant, in the combination types of HRT, including the combination HRT patch, contain a synthetic progestogen. And that again is really important because metabolically they're very different to the pure progesterone. So when you look at risks of HRT, the risks are associated with the synthetic hormones. So with the breast cancer risk, with the WHI study, this was with medroxyprogesterone acetate, which is a type of synthetic progestogen. When we look at the risk of clot with progesterone and stroke, then that's with the synthetic progestogen. When we look at a lot of the side effects, is with synthetic progestogen as well. So again, we should only be using the word progesterone if it's the pure, biochemically exactly the same formulation as the progesterone we produce when we're younger. So that's why when we talk about body identical hormones, it's really biochemically exactly the same as the hormones we produce. And we have to be really pedantic here, and I'm sort of thinking, well, we should just be calling them natural hormones because that's what they are. So estradiol, progesterone, and testosterone as well. And there's always been this reservation about testosterone, that it's really a man's hormone, and of course it's not. Men produce estradiol and progesterone, and women produce testosterone, and we produce more testosterone than estrogen when we're younger. And a lot of it comes from our ovaries, but it also comes from our adrenal glands and from our brains as well. And levels decline at different rates as we age. It is derived, the word testosterone is derived actually from testis, so the scrotum, the testis in the scrotum from bull, from cows. Really derogatory actually, because we don't have testes. The word shouldn't even be testosterone, it should be, some people call it androgens, but then it's still not a male hormone. We produce it as well, we just produce different amounts. So that's where it can become very confusing with these hormones, because when we say HRT, are we meaning estrogen? Are we meaning different types of estrogen? Are we meaning estradiol? Are we meaning progesterone or synthetic progestogens? And are we meaning testosterone? And increasingly, people think HRT is just estrogen and progesterone. So often people say HRT and testosterone. And that's why I think we should just be using similar terminology. We should be calling it out for what it is. So estradiol, progesterone, testosterone. If someone's given a synthetic progestogen, we should say it. It's a synthetic progestogen. It's not the same as a natural hormone. Because once you understand that, and once you understand how they work differently in the body, then it makes it a lot easier. And a lot easier when we're thinking about why we give hormones to women. So there are different reasons, obviously, why we give hormones, but we give them to replace the missing ones. And that can vary. So if someone is menopausal, which officially, as you know, has to be a year since their last period, but essentially it means that the hormone levels have gone down and they've stayed low, and they will be low forever. And there is always going to be a bit of fluctuation, of course, because other tissues produce hormones as well. But essentially the hormones are low. And so when we give HRT or hormones, natural hormones, to women who are menopausal, then it's usually a steady dose that we give, but the dose might need to be titrated. So if I see someone in the clinic who's elderly, maybe in their 70s or 80s, never been on HRT before, then I'll often start with a very low dose. But that might not be enough to fully optimise their symptoms, so with time the dose might need to be titrated up a little bit. It really varies. But we tend to give, it's easier when you start hormones in people who are menopausal because they don't have their own hormones fluctuating. But we already know, and many of you know, that actually it's better to start hormones when we're younger, when we start to experience symptoms. And that's for two reasons. Firstly, because giving hormones back will improve symptoms. It will reduce symptoms. It will improve quality of life. And actually that's really important, that people aren't suffering. But we also know once our hormone levels decline, we've got more inflammation in our body, more risk of future diseases. So to keep women as healthy as possible and as symptom-free as possible, then we know starting hormones earlier is better. But the problem often, not always, is that when we start hormones when we're perimenopausal, our own hormones are fluctuating. And so it's really hard to match the missing hormones because they can fluctuate in minutes or in hours or in days. And so how do we know that deficit? And there's no way of monitoring hormone levels all the time. So often it is a bit of guesswork. And sometimes what happens is if people's hormones are really fluctuating a lot, then we give a higher dose to suppress their own hormones so they don't get this fluctuation, so then they can reach a steady state and feel a lot better. We also often give hormones to women who have PMS, premenstrual syndrome, or PMDD, which is premenstrual dysphoric disorder, which is a more severe form. People get more severe symptoms, either mental health symptoms or physical symptoms, or often both. And usually, not always, but usually those symptoms are present in the few days before periods. And if a woman, say for example, is only having those symptoms for 3 or 4 days every month, and the rest of the time is feeling absolutely brilliant, then it makes sense to only give the natural hormones on those 3 or 4 days a month, because then you're just increasing the amount because they get a big decline before their periods. They don't need hormones the other times of the month because they're feeling fine. And that's where it's really important, not just the dose that's individualised, but how we give it and when we give it. But the other thing is which hormones, because traditionally we're always told you give estrogen, you give progesterone if they have a womb, and testosterone is only for reduced libido, but they have to be on HRT first. Now, if we think physiologically how these hormones work in their body, it actually doesn't quite make sense to do that. And I feel a bit cheated as a doctor. No one really sat down and taught me basic physiology many years ago. It's just something that's just been sidelined for many years. But because these 3 hormones are different, they have different effects in the body, like I've said, but they can decline at different rates. So I've seen people, for example, who have had, I don't know what's happened there, sorry. I've seen people, for example, who have had PMS or PMDD, and it's the progesterone that they've been missing more than estrogen, more than testosterone. So those women only need progesterone to start with. I've seen women with endometriosis who find that any estrogen can flare up their endometriosis, so they prefer to have progesterone and maybe testosterone if they're low in testosterone. So it really varies. Many of you have asked about progesterone if you've had a hysterectomy and been told that you don't need progesterone or you've got a Mirena coil in. And I have done an Instagram live that's on my YouTube only about progesterone, and I'll share it on my stories later. So progesterone is a biologically active hormone that works all around our bodies. So many people benefit from progesterone, whether they've got a womb or not, whether they're on estrogen or not. And so individualising the hormones, as in when to start them, is really important. When women have a womb, if they only have estrogen, there can be an increased thickening of the womb. And many years ago, actually in 1974, or before 1974, when HRT was first sort of discovered, they realised that they could mass produce it using pregnant horses' urine. So in the 60s, there was a lot of hormone prescribing, but they only gave the conjugated equine estrogens. They found there was a small increase of cancer of the lining of the womb. So then they also found that could be reduced by having a synthetic progestogen, which is great. But so now we're taught that we should be giving a progesterone with estrogen for women to protect the lining of the womb. But actually there's no evidence that the natural estradiol causes cancer of the lining of the womb. We know it can cause thickening of the lining of the womb because that's what happens physiologically. So the first half of our cycle, the lining of the womb builds up, we have more estradiol, and then the second half, obviously, if there's no egg and there's no pregnancy, then the progesterone and estradiol decline, we shred the lining of the womb and have a period. So we know that it can cause something called hyperplasia, which is thickening of the lining of the womb. But there isn't any good evidence that estradiol on its own will cause cancer. It can cause thickening and it can cause bleeding. And bleeding can be a really common symptom, which is really frustrating. And a lot of people go for investigations when they have bleeding, quite rightly so. But we need to be clear that it doesn't mean you have to stop taking your HRT. And a lot of people recently have been telling me that they've been told they have to stop their HRT because they've had bleeding. You don't have to stop your HRT, but the dose might need changing. And sometimes it's because the dose of estrogen to progesterone needs altering. Some people need a lower dose of estrogen, some people need a higher dose of estrogen. We find often in the clinic if people are on too low a dose of estradiol or they're on a patch that maybe isn't sticking well, it can destabilise the lining of the womb and cause more bleeding. And if they're not absorbing well, if we increase the dose, actually it can help and reduce bleeding. Conversely, some people might be absorbing more and leading to thickening of the womb, and then we can reduce the dose if it doesn't trigger symptoms, or we can increase the dose of progesterone or use the progesterone vaginally rather than orally, for example. So there are lots of options for bleeding, but it doesn't mean you have to come off your HRT. Obviously, if you stop your HRT, you won't have bleeding, but you won't have any of the health benefits from taking HRT or the symptom improvements. So it's important that we don't treat everyone the same. And bleeding doesn't mean cancer. There's lots of reasons why people have bleeding. And again, I've done an Instagram live all about bleeding. But just to reassure you, actually, there's been a lot of confusion that estrogen causes cancer. The conjugated equine estrogens probably do because they contain all sorts of other things, not just estrogens, but progesterones and progestogens, and actually some androgens as well. So they might cause cancer, but we don't use them. We just use the natural estradiol. So, and then with the testosterone, a lot of people are told they have to be established on HRT, they have to be on an optimal dose of estrogen, and then only if they have really severe reduced libido. And some clinicians say people have to have fulfill the whole criteria for HSDD, hypoactive sexual desire disorder, which essentially means that you have to be severely psychologically distressed with your reduced libido for at least 6 months. I think that's quite harsh, actually. As a doctor, I don't want to watch people suffering for days, let alone weeks or months. And also, we know physiologically testosterone works all around our body. It's produced in our brains. It's very good for mood, energy, concentration, stamina. It can also help build our muscle and bone strength and help with our cardiovascular system as well. And I've done an Instagram live about testosterone. So some women lose their testosterone before they lose their estrogen and progesterone. So they might be having regular periods, but then start to become very tired, very low in their mood. They might have urinary tract symptoms, and you do their testosterone level and it's very low. And so sometimes you give a therapeutic trial, you give us a course, if you like, of testosterone. They might need estrogen and progesterone as well, and then review and see. So we don't always have to give the same dose to the same person, and we don't have to start the hormones in the same order for the same person. And that's important because we are all different. So we lose our hormones at different times. And I think so much in medicine is guideline driven, so we have to think about treating everyone exactly the same. But how can we? Because we're all different. So the other thing, a lot of people have asked about the dose, and they've mentioned NICE guidance. Now, the NICE menopause guidance came out in 2015, so quite a few years ago now. But it doesn't mention anything about dose. It doesn't say anything about the maximum licensed dose. It says that we should individualise dosing to improve symptoms. When a drug company license a medication, they have to put in for a licensed maximum dose in the UK and other countries as well. But with the HRT, or with the estrogen, the maximum dose was just on tolerability. They didn't do long studies. I've done another Instagram live talking about this in detail. But in a short summary, basically the studies that the drug companies did for the patches and gels all of them used less than 40 women. Most of them were around 30 women, and they only tested for about 4 days on average, because what they wanted to really test was, does the patch stick on, does the gel get absorbed, yes or no. That was all. So they weren't looking at any long-term safety, they weren't following these women up or anything like that at all. In some countries such as Belgium and I think Italy, the dose of estrogen gel, there isn't a maximum amount. But what the guidelines all say is that women should have the right amount to improve their symptoms. Now, some people it might be a very low dose, other people it might be higher. But we have to think about what are we doing? How are we giving estradiol? So we usually give it as a patch or a gel. There is a spray, but in our clinical experience we find it's quite unreliable to absorb. But if you think about the patches, and I've got one here to show you, and you might have seen them before, they're just square patches and they've got glue on them. Now the estradiol is in the glue, and so if it sticks really well, then it's going to absorb better through the skin. But our skin is a barrier, so when we rub in our sun cream or our moisturiser or our hand cream, we don't really want it going in our bloodstream. There's not many drugs that can be absorbed through the skin as a patch. Nicotine is one, some painkillers such as fentanyl can be absorbed, and estradiol can be. Progesterone doesn't get absorbed very well or reliably through the skin, but estradiol can. But it's only how good it sticks is the first thing. But the second thing is our skin type, because the blood vessels are on the surface, but we want the deeper blood vessels to absorb the estradiol as well, so it gets all through our body, of course. But it depends on the skin texture, on the temperature of the skin, whether the blood vessels are on the surface or deep down, even the collagen on the skin. There's lots of reasons why people will need different doses. And we also know from studies, they did studies putting the patch on people's bottoms or their backs. Now on the back there's very little usually subcutaneous fat, and on the bottom there's more subcutaneous fat, and on the thigh there'll be a different amount. So if I use my patch in one area, so my thigh, and then the next week put it on my back, the absorption can change. And this study, or one of the studies I've read, the absorption changed by a factor of 22. Massive amount, isn't it? So even depending on the same person, the amount can really vary depending on where you stick the patch. And between people it will vary quite a lot. We've written up our data, which is going to be published soon, which will reveal a lot more about the variability. But it's just to show that if a patch, and I don't stick my patches on my hand, but I'll show you, if it sticks on really well, then I might only need a smaller patch. But if it doesn't stick on well, and this is just showing you the bigger size of another one, I might need a bigger patch. So you'll see I've got a smaller patch and a bigger patch. But if I absorb not very well from here because the patch crinkles, like some of you might have seen mine does, whereas this is someone else's skin and it sticks really well, it's really smooth, then this person might be absorbing more than this person, even though this person's on a higher dose. Quite simplistic medicine. I've spoken to lots of pharmacology experts who say, I don't know why you're so worried about this, because it's so obvious that it really varies so much. But I do worry because people are told different things about the dosing. But the other thing, it's not just the patches. Just take these off so they're not sticking on my hand all the time. It's not just the patches, it's the gel as well. And this is one of the commonest gels, but many of you I'm sure have seen it before. It's just a clear gel that gets rubbed in, and when they license it, they have to say where to put the gel and where to stick the patches. So usually the gel, the way it's licensed, is on the outside of the arms, the inside of the thighs. But actually it can be used anywhere because you're using the skin as a vehicle. So that was just the way it was licensed. But if people find it more convenient to rub onto their shoulder or onto their calf, yeah, that's fine, as long as it gets absorbed. Now the gel actually gets quite absorbed quite well for me. I just find that I need to use more of it, and then I get a bit sticky. But you can see it's already gone from my hand. Many women say to me that they're literally dripping. They put it on and it slides off, and I've seen women in the clinic show me, and it's literally just slides off and doesn't get absorbed. So they can use hundreds of pumps, but if it doesn't get absorbed, nothing's going to go into their body. And so it's really important, if someone's got symptoms and we think they need a higher dose, the first thing I ask is, does the patch stick well? Or are you finding that the gel goes through your skin very easily? And so if people say, no, the patch doesn't stick very well, or no, my skin is really slippery and it's not being absorbed, the first thing I'll do is change formulation. So they might have the same dose equivalent, but I just convert them from a patch to the gel, for example, or gel to patch. And then they go, wow, this is amazing, I feel so different. So that's something that we often do. And there are different manufacturers of patch, there are different manufacturers of gel. So actually sometimes just changing from one manufacturer of patch to another can be enough of the same dose. But some of you might know that I use more than 100 microgram. And when I started HRT 8 years ago, I saw my male gynecologist, and he said to me after like 3 months, I wasn't feeling any better. I said, well, that was a waste of time. I don't feel any better on my hormones. Really disappointing, because women keep telling me how much better they feel. So he did my estradiol blood test, and it was low. It was about, I think it was 110. And he said, well, you need to double your dose, you're not absorbing it. And at the time I said, oh, well, I've never prescribed such a high dose. And he said, well, it's common sense. If it's not sticking very well, just double it. We'll do your level in a few months' time and see. And I quite quickly noticed a big improvement. And then my repeat level was 268, which is better, but it's not hugely high. We know on average that women who have their periods, their estradiol level ranges between 250 and 1,000, but it really varies. And again, not good studies have been done, and we're all different. But if an estradiol level is low and someone's getting symptoms, it's a guide that we can increase the dose. But we have to not be caught out, because when people are perimenopausal, I've already said they can be releasing their own estradiol. So you might find that a person's level or your level is quite high. Don't think you've automatically got to reduce your dose. It was worth repeating the level, because you might find that was taken when you were producing a lot of estradiol yourself. And then at another time it might be lower. So especially if you think you're perimenopausal. The other thing is, don't do the finger prick testing, especially for estradiol levels, because they get hemolyzed. The blood that you get from your end of your fingerprint is a capillary blood test, not when you have it from your arm, it's a venous blood test. And so they're very unreliable. We've done quite a lot where we've tested the same woman doing finger prick and venous, and they've been like 1,000 times different, like really obscure, really, really high levels on finger prick. So I wouldn't do that as well. So we can increase the dose. When we increase the dose, we're not giving more estrogen, actually, we're just allowing the right amount to be absorbed through the body. And so there's been a lot of confusion. If you increase the estrogen, do I need to increase the progesterone? And again, it depends if people are having bleeding, how they're absorbing the estrogen, whether they need more progesterone. It really varies. There isn't any evidence to show that a certain dose of estrogen means a certain dose of progesterone, because we're all different and we absorb differently. And we're looking at all our data in our clinic and finding some really interesting results that we'll share with you. The other thing I wanted to share with you is that we have to be careful as clinicians. When we do blood tests, we take them in context. So that's why it's really important to have any blood tests interpreted by someone who understands hormones, because out of context, you can either be falsely reassured or falsely concerned. And I wanted to just show you, and I'll put them on my story later. These are hormone levels that I did of someone who's very stable on hormone treatment. So this is someone who's been on hormones for more than 6 years. She uses patches and she also uses testosterone, same amount every morning. And what I did was do her blood test 8 times in a day, the venous blood test, because I wanted to see how whether it was quite reliable, the blood test that we did. So the first one I'm going to show you is the estrogen blood test, and you'll see there's a real variation. This is in the morning, about 10 o'clock in the morning, and this is the evening. So I could have done the blood test here and said, oh, your level's quite low, we need to increase. But then I could have also done the blood test here and it went up to 1250 and said, oh gosh, that's a little bit high, you need to reduce. But actually this person feels absolutely fine. But I wanted to show you there's so much variation in estradiol from somebody who's on a stable dose. And this is probably because she's metabolizing it differently. She's probably producing estradiol in her own tissues. There's so much that we don't know, but it's just we can't take things out of context. Testosterone levels, again, are a really useful guide, but we are all different. I don't know what my average testosterone level was 10, 20 years ago, and I'm never going to, of course. But actually, I don't want to be how I was 10, 20 years ago. I want to absorb the right amount of testosterone for me. And often it is on symptomatic improvement. Very, very few people have side effects from testosterone when it's prescribed in the right way, and side effects are usually reversible. But this is somebody who had the testosterone levels done 8 times in a day. And you'll see this is the morning, quite stable for a chunk of time, small increase, and then it really increased. This was at like 6 o'clock in the afternoon, and then it went down a lot, and actually just before she went to bed at 10 o'clock it was really low. And this is quite interesting, I think, because as a clinician, if I had done a blood test and found that it was high, and this went up to like 3.5, I would have said, oh, your level's a bit high. But then if I'd done the level later, I would have said, oh, your level's a bit low, you can increase. But actually I didn't change the dose in this lady because she was absolutely fine. I speak to a lot of women who are told, come off your testosterone, reduce your dose because your level is high. But what we should do is repeat it. If someone's not getting side effects and they're feeling well, then often we repeat it after a few weeks and see and put it into context. So even when someone's stable on hormones, they can still have a huge variation in their levels. Progesterone levels we often don't do because, again, they can really vary. But the other thing to mention is that these hormone levels are in the blood. Actually, if someone has got really bad psychological symptoms, they're feeling very low, they've got anxiety, poor sleep, it's the brain that needs it. There's no way currently that I can measure the amount of hormone in their brain. I can only measure the amount in their blood. And we do know from some evidence, even some evidence from 1979, shows that some women who have severe psychiatric disturbances need a lot higher doses of estrogen, because to get through to the blood-brain barrier, to get into the brain, higher doses are needed. And some studies have shown very much higher levels, which has been transformational for women in psychiatric hospitals. So there's so much we need to look at properly. We need to be looking at dose of estradiol, not the older types of estrogen. We need to be looking at progesterone as its own independent hormone, and also the metabolic differences of using it orally and vaginally, the different dosing effects as well. And also testosterone as well for symptoms, not just improving libido. And a lot of this we are writing up from our clinic, which is really going to help individualised care. We spend a lot of time in the clinic enabling people to have the right dose and type of hormones. And just before I finish, I wanted to mention the vaginal hormones because they're different as well. We have the pessaries, and I've just got one here that many of you will have seen in the UK, which is called Vagifem, which is a single use. It's got a little tiny estrogen tablet in it that's used once a day for 2 weeks, and then it's twice a week thereafter. But the game changer for me that's really changed my clinical practice that I've mentioned before is Prasterone. And this is a larger pessary. I'll show you what it looks like. It's like a waxy pessary. It can be self-inserted, or you can use an applicator that can be reused, so more environmentally friendly. And it's a daily pessary. But this contains DHEA, which converts to estradiol and testosterone. And we have androgen receptors in our vulva, vagina, urinary tract. So if you're only using Vagifem, you're only half treating, whereas this is treating more. And people I've seen have been transformed with their local symptoms, their urinary symptoms, and these can be used with or without systemic hormones. Really good option for people, especially those who don't want to maybe take hormones but are having localized symptoms. And but it's very safe even if you're on systemic hormones as well. So we mustn't forget the urinary tract and our vaginal symptoms as well. But progesterone, it has just transformed my clinical practice over the last few years. So we're all different. The type of hormones that we have, the order we have them, the dosing of each is all different as well. There is an article that we've written that is on our Newson Health website, which I will show you how to access and download the PDF and put it on my story later so you can read it. It is referenced with some of those references from the 32 Women for 4 Days. And it might be useful if you're finding it difficult to get the dose that you feel that you need. You might want to share that with your healthcare practitioner and talk about the options, because there isn't a maximum dose. Like I say, we are all different, and I know personally if I was on a lower dose I wouldn't be able to function, I wouldn't be able to work, and I don't absorb enough. And I know that I'm not the only woman that needs a different dose. So I hope that's been helpful. I've noticed I've not got my glasses on, so I can never read your comments. I'm really sorry. If there's anything you want to ask me, put them in the grid when I put this on my Instagram, because I purposely don't wear my glasses so I don't get distracted. But then you could be telling me anything and I really can't read it. So you can put them in the comments so I can read them. I realise that I have just gone over half an hour, but there's a lot of information to share. I hope you found that really helpful. Give me topics that you really want me to talk in more detail on future. It will be Sundays, it's only because of the bank holiday. And I hope some of you are booking or have booked tickets to the tour that's going to come up quite soon. So enjoy the rest of your evening, and thanks for all your support. And I really hope all the work that we're doing is making people better, healthier and happier. So enjoy. Thank you.